Carpal tunnel syndrome is a collection of characteristic signs and symptoms that occur following compression of the median nerve within the carpal tunnel. The median nerve is damaged within the rigid confines of the carpal tunnel, initially undergoing demyelination, followed by axonal degeneration. Sensory fibers are affected first, followed by motor fibers. Autonomic fibers may also be affected. The exact mechanism of this damage is not well established. However, some theories suggest that abnormally high carpal tunnel pressure causes obstruction of venous outflow, with resultant edema formation, ultimately leading to nerve ischemia and damage. Carpal tunnel syndrome is not fatal. However, it can lead to complete, irreversible median nerve damage with consequent severe loss of hand function if left untreated. Whites are at a higher risk of developing carpal tunnel syndrome. The peak age range for the disease is between 45 to 60 years, and about 10% of cases are reported in people aged less than 31 years. Females are commonly affected than men, with a ratio of 3 to 10 to 1. Now let's discuss about the causes and risk factors of carpal tunnel syndrome. Many different factors influence the risk of developing the disease. They can be categorized into demographic, genetic, activity-related factors, and medical conditions. Demographic factors include the following: increasing age, female gender, square-shaped wrists, dominant hand, high body mass index, short stature, and white race. Medical conditions that can lead to carpal tunnel syndrome include the following: space-occupying lesions in the carpal tunnel, including flexor tenosynovitis, ganglion, hemorrhage, aneurysms, and tumors, wrist fractures, diabetes mellitus, acromegaly, thyroid disorders such as myxedema, rheumatoid arthritis, renal dialysis, and amyloidosis. Genetic susceptibility also plays a major role in the pathogenesis of carpal tunnel syndrome. Other conditions associated with the disease include the following: prolonged, severe force through the wrists, high amounts of repetitive movements, exposure to vibration and cold, lack of aerobic exercise, pregnancy and breastfeeding, and use of wheelchairs and walking aids. Now let's discuss about the clinical presentation of carpal tunnel syndrome. Symptoms of carpal tunnel syndrome are usually intermittent and are associated with certain activities such as driving, reading books, etc. Nighttime symptoms that wake the individual from sleep are more specific for carpal tunnel syndrome, especially if the person relieves symptoms by shaking the hand and wrist. Many patients complain of dropping things from hands due to the loss of grip. In addition, they also present with numbness and tingling over the palmar aspect of first to fourth fingers and the distal palm, which are the areas where median nerve gives its sensory supply. These symptoms are often accompanied by an aching pain over the ventral aspect of the wrist. This pain can radiate distally to the palm and fingers, or more commonly, extends proximally along the ventral forearm. On examination, wasting of median innervated muscles can be seen. These muscles can be remembered by the mnemonic LOVE, where L stands for first and second lumbricals, O stands for opponens pollicis, A stands for abductor pollicis brevis, and F stands for flexor pollicis brevis. Many patients with carpal tunnel syndrome also complain of a tight or swollen feeling in the hands and temperature changes. In more rare cases, there are complaints of changes in sweating. These symptoms are due to damage to the autonomic nerve fibers, since median nerve carries most of these fibers to the hand. Now let's come to the diagnosis. Abnormalities in electrophysiologic testing, in association with specific symptoms and signs, are considered the criterion standard for the diagnosis of carpal tunnel syndrome. Special tests that are useful in the clinical examination include the following: Hoffmann-Tinel's sign. Here, gentle tapping over the median nerve in the carpal tunnel region elicits tingling in the nerve's distribution. However, this test has a very low sensitivity and specificity. Phelan's sign, where tingling in the median nerve's distribution is induced by full flexion of the wrists up to 60 seconds. This test has 80% specificity, but a low sensitivity. Carpal compression test is another method which has 95% specificity and 90% sensitivity. Here, a firm pressure is applied directly over the carpal tunnel with the thumb for up to 30 seconds to reproduce symptoms. Finally, we have the square wrist sign, which measures the ratio between the wrist thickness and wrist width. If the ratio is more than 0.7, it is a positive test. This test has 70% sensitivity and specificity. Electrophysiologic studies are the first-line investigations in patients with suspected carpal tunnel syndrome. These include electromyography and nerve conduction studies. Finally, let's come to the treatment. Since carpal tunnel syndrome is associated with low aerobic fitness and increased body mass index, many patients are advised to engage in aerobic exercise and weight loss programs. Stationary biking, cycling, or any other exercise that puts strain on wrist should be avoided. Medical management can be done in several ways. Many patients with mild to moderate carpal tunnel syndrome respond well to conservative management, consisting of splinting the wrist at nighttime for a minimum of 3 weeks. Steroid injections to the carpal tunnel have been shown to be of long-term benefit and can be tried if more conservative treatments have failed. Injections may also be given prior to surgical management or in cases where surgery is contraindicated, such as pregnancy. Patients whose condition does not improve following conservative treatment and patients who initially are in severe carpal tunnel syndrome category should be considered for surgery.